Welcome to this video tutorial titled Upper Limb Movement Analysis and Introduction. I'm Kylie, an occupational therapist working in clinical practice and education in a community-based rehab clinic in Queensland, Australia. Is this video for you? Well, if you're an occupational therapist or a physiotherapist or an OT or physio student getting started in neuro rehab, particularly in stroke and brain injury, then perhaps yes. The purpose of the video is to give you some basic knowledge and confidence to go on to do more in-depth training, which I'll provide links for later. By the end of the session, you'll hopefully be able to describe what upper limb movement analysis is and how it adds value. You'll be able to name basic movements of the upper limb and conduct a movement analysis in which you'll identify expected, missing and excessive movements, and you'll start to recognise some links between these. What we won't cover in detail is hypothesis testing and planning evidence-based therapy, but you'll be able to locate training to learn more about this. So first of all, what do I mean when I say upper limb movement analysis? Well, basically, I'm talking about doing a task analysis, but specifically for movements of the arm or hand when doing a real-life activity. During the analysis, you can be aware of what movements you'd expect to see in an unaffected limb doing that task, and we'll call those expected movements. And you'll compare those to what movements you actually see in the affected limb. Where there is more movement than expected at a joint, this is considered excessive movement, and where there's less movement in a joint than expected, this is considered a weak or missing element. So now let's see it in action. So here the person is reaching with their unaffected limb while the therapist records expected movements at the trunk and each of the upper limb joints. And here's a clip of the same person reaching with their affected limb, and the therapist is now recording missing and excessive components. And the therapist can then look for links between these elements to plan therapy. So how does this process add value? Well, a standard screening battery is a bottom-up approach that might include tests of impairments that are common after stroke or brain injury. Things like manual muscle testing, measures of passive and active range and pain and sensation, shoulder subluxation, edema, spasticity, grip strength and coordination, or dexterity tests. And this process certainly has its place, especially for working out what specific impairments there are and doing hypothesis testing. In particular, this process helps you to identify risks for complications like stiffness or pain. But sometimes the outcome can be a long list of impairments, and it can be hard to know where to start for movement retraining. A task analysis that uses a meaningful activity and objects can help by providing a top-down approach. It might guide you to understand the links between impairments within function, and that may help you to prioritise the most important impairments or movements to focus on first to enable that person to get back to their meaningful tasks. Before we give it a go, it's helpful to revisit the terminology for arm and hand movements. So let's start with the scapula and work distally. At the scapula, we might see elevation and depression, protraction and retraction, upward rotation and downward rotation. At the shoulder, elevation and depression, flexion and extension, shoulder abduction and adduction, external rotation and internal rotation, horizontal abduction and horizontal adduction. At the elbow, there's flexion and extension. For forearm, there's supination, pronation, and for wrist, extension, flexion, ulnar deviation and radial deviation. For fingers, there's flexion, extension, abduction and adduction. And finally, thumb flexion, extension, thumb abduction, adduction, and opposition. If you'd like to practice naming these movements, why don't you mute the sound, go back to the start of this section and see how you go. So now we're more confident to name movements, let's clarify the steps in conducting the movement analysis. First, you'll prepare the task and equipment. Next, you'll identify the expected movements for the task. Then you'll watch the affected limb do the task and notice which movements are missing or excessive compared to what was expected at each joint and the links between these. Then you'll generate hypotheses about why those missing or excessive movements are happening, and you'll choose evidence-based therapies to address them. But those last two steps are beyond the scope of this tutorial, so let's step through the first few. Preparation might involve deciding with the person on a meaningful activity that they can almost do correctly, set up a space and the objects for that task, print a movement analysis form. The one we've used is adapted from a tool described by Ray et al., which you'll find a reference for at the end of this tutorial, but there are certainly others out there. You may wish to have a camera or video recording device, and if you do, you'll likely need a photo consent form for your organisation. Next, watch and perhaps photograph or film the unaffected arm doing the task and jot down the expected movements. You can practice this using the final frame in this clip of reaching for the water bottle, so go ahead and pause the video and see if you can name each component. Okay, let's see how you went. The trunk is stable, and although we can't see it, it's likely the scapula is too. Shoulder is in about 40 degrees flexion and neutral rotation. Elbow is in about 160 degrees extension. The forearm in mid position. Wrist extended to about 45 degrees. Fingers are extended at the MCP joints and IP joints are slightly flexed. The thumb is abducted. How did you go? The next step is to watch and/or record the person doing the task with their affected arm. Can you pick out the joint movements that are excessive and missing in this final frame? You may want to pause the video now to do this. From what we can see, there is likely excessive trunk flexion, and we can't see the scapula to check what's going on there. There's also more shoulder abduction than we saw for the left arm. What's weak or missing is shoulder flexion beyond 20 degrees and shoulder external rotation beyond -20 degrees. There's also less elbow extension. It gets to about 120 degrees instead of the 160 degrees we saw on the other side. And there's perhaps some end range wrist extension missing beyond 30 degrees. Your next step will be to look at the pattern of missing and excessive movements to formulate hypotheses about why this is happening. So for example, is there too much trunk flexion to compensate for not enough shoulder flexion and/or not enough elbow extension? Is there too much shoulder abduction to compensate for missing external rotation and/or wrist extension? We can then test these hypotheses. So for example, if we test wrist extension and find there is enough active range when the person is concentrating only on that movement, then perhaps we can add a target like the bent straw to draw attention to that element during practice. The straw in this picture would be bent further backwards for that effect, and that might prompt the right amount of wrist extension to be generated, which in turn may reduce the compensatory shoulder abduction. And similarly, you may want to add targets to encourage external rotation for that effect as well. And then you might consult an evidence-based source like the stroke guidelines to choose therapy that focuses on improving those elements. So for example, evidence regarding task-specific practice suggests that hundreds of repetitions a day over a few weeks may be needed to get changes at the brain and performance levels, but that's another tutorial. If you would like to practice the movement analysis steps again, here's another example. You can pause the video, name the expected movements from the photograph on the left and the missing and excessive components on the right. The red lines and arrows will give you some clues. And maybe you can generate some hypotheses about links and think about some evidence-based therapies for this goal. And this could be a great activity to do with a colleague. If you'd like more training support, particularly around hypotheses and therapy planning, here are some sites to get you started. Strokeed.com has a range of free online resources as well as information about upcoming training events. At informme.org.au, you'll find a link to this online learning module on recovery of the upper limb. You can also follow the link under guidelines to view the living stroke guidelines for evidence-based recommendations for therapy. So let's review what we've covered today about upper limb movement analysis. We've learnt that it is a task analysis that uses a meaningful object and activity that the person can almost do. We've discussed that its value is in helping to prioritise movement retraining. This is done by identifying the expected, missing and excessive movements and hypothesising the links between these. And you've seen where to go next for further training, particularly for hypothesis testing and evidence-based therapy. If you would like to give any feedback about this video, please feel free to leave a comment below and consult these references for further information.